Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I'll be your host this evening. Tonight is Sunday, October 31st, 2021. Happy Halloween to those of you that are celebrating or have little ghosts and goblins in your house that you've taken out trick-or-treating. Tonight, given that it's a Sunday, it will be a caseless question night. So we will be taking volunteers. If you've had a chance to be in the hot seat, let's say last Wednesday, maybe even last Tuesday, if you could let your colleagues again have a shot at the hot seat, that would be appreciated. If we don't have enough volunteers, by all means, happy to have folks that even have participated, of course, recently. For those of you that are taking the test this week, before we get started, I wish you a very good luck wishes, and let's get started. So let's see here. Bethany, I'm trying to take you off of mute.
Can you hear?
Yep, can hear you now.
Excellent.
You're a generalist, if I recall. Is that right?
Yes, I sure am.
Okay, let's see if I can find your list. There it is. Okay. And should be coming up momentarily, and then so so patient number 6 was a 24-year-old nulliparous patient. She had pelvic pain and a right ovarian complex cyst that was 8 centimeters. Failed medical management, and tumor markers were negative. We did a robotic assisted left LSO for 14 centimeter left ovarian cyst. It was basically a mature cystic teratoma and benign left fallopian tube. So first of all, Bethany, how do you account for the difference in the side of the mass?
Yes, so I believe it was actually just due to a rapid growth and error in ultrasound estimation, because the time that elapsed between the ultrasound and the surgery itself was only a matter of about 3 weeks. So I do believe that it was just a rapid growth, which was matched her clinical scenario, because she was having severe worsening of pelvic pain as well during that time.
So why did you, well, first of all, what tumor markers did you get?
Yes, so I got alpha fetoprotein, LDH, and CA125 for the patient, as well as CA19-9.
Can you tell me what type of ovarian malignancies would produce CA125?
Yes, CA125 is a tumor marker for epithelial ovarian cancers.
Is it all epithelial tumors?
Particularly serous tumors.
Okay. You mentioned CA19-9. What type of malignancy would produce that?
Mucinous tumors.
Okay. Anything else you can think of for CA19-9?
I believe that it can also be associated with like other organs as well, like other GI structures.
Can you be more specific or not really?
I will no, I'm not at this time.
Okay. So you mentioned, let's see, I think you said AFP as well, right?
Yes.
And what type of tumor or malignancy would produce AFP?
Like an endodermal sinus tumor or a yolk sac tumor.
Okay. And what was the other tumor markers you said?
I believe LDH and beta HCG.
Okay. What produces LDH?
A dysgerminoma.
Okay. And what about the HCG?
Like a choriocarcinoma or possibly a dermoid.
So dermoids produce HCG?
I believe in some instances they can.
Would that be a mature or immature cystic teratoma?
I would have to look that up to be more specific.
Okay. So I assume these were negative because, well, it says so. Why'd you use the robot for this patient?
Yes, so I used the robot for this patient since I was anticipating a large cervical cyst. I felt that the robot would be able to give me a better 3D visualization of the cyst. I felt it would decrease my risks of ovarian rupturing of the cyst and also help me to preserve as much ovarian tissue as possible. Unfortunately, the
Okay.
cyst turned out to be much larger than I was anticipating, and I did end up having to perform a unilateral salpingo oophorectomy on the patient, but that's why I elected for the robotic case from the beginning. Also of note, this patient did have a history of pelvic inflammatory disease in the past, and I was anticipating possible adhesions for her as well.
Um, so why did you end up taking the? I mean, I heard you say it was bigger. Obviously, it was, but you didn't know that going in. So what? I guess why'd you end up taking the ovary? I mean, was there no normal tissue?
There wasn't. The ovary was so it was so um, not its normal anatomy had been stretched so thin, it was incredibly difficult to differentiate out the ovarian tissue from the cyst tissue.
Okay. What about trying to spare the left fallopian tube?
Since she did not, the left fallopian tube was very much so adhesed and involved with the very large cystic teratoma. And also, since I was already taking her ovary for that side, I didn't feel that that was going to necessarily contribute to her fertility since I was already taking the fertility from that side. And so the decision was made to proceed with removing the tube as well.
So is that true? So if you take out a patient's ovary on one side, um, taking out the fallopian tube really doesn't matter if it's from the same side?
No, I see your point. It could still help with fertility purposes. I guess when I was looking at the tube, it looked so damaged. It was so severely scarred and damaged, it didn't appear to be functional. And it might even increase our chances of an ectopic pregnancy due to the severe scarring and fibrosis of the tube.
I'm sorry, it might. Okay, I got you. So, what's the most common type of tumor to cause ovarian torsion or predispose a patient to torsion?
I believe either a functional cyst or else a mature cystic teratoma.
Well, which is it?
Of teratoma.
What is if you had a patient that had let's say this patient had her adnexa was twisted on itself. Let's say you were able to potentially separate the cyst from the ovary, but it had undergone torsion. Under what circumstances would you remove a torsed ovary?
I would very rarely remove a torsed ovary, even if the ovary didn't immediately look pink or if it appeared dusky. I would still try to leave the ovary in place because it could still have residual function, and I would want to keep that ovarian function if at all possible, especially in a young patient.
Okay. All right. I think I guess we might as well stop here and we can go over it.
Okay.
So why did you get all those tumor markers, especially since you only thought it was 8 centimeters when you were getting them?
Yes, so I don't have GYN oncology available. So honestly, it's because it's a clinic policy that anytime we have a complex mass, we're supposed to have negative tumor markers before bringing them to the operating room. But normally, I wouldn't get tumor markers for something that was as distinct as a dermoid cyst on imaging. It's
Was this
more because it's a clinic policy that we follow.
so? Was this actually a looked like a dermoid on on
It
ultrasound?
very much so did, yes.
Um, okay. I think, in presenting this case, Bethany, and again, we weren't really presenting it literally, but the salient point about the robot would be the history of the PID. That's kind of critical.
Okay.
That would be something you definitely would want to volunteer early in the discussion. Again, if you're talking about indications for robots and the potential with scarring, because I mean that would be more understandable as to why you might why you might want to employ the robot. Let's see, and be careful with the fallopian tube because obviously just because you take out the ovary doesn't mean she couldn't get pregnant from the
Yes, thank you.
contralateral.
Right after I said that, I regretted it.
In terms of tumor markers and tumors, so pretty much everything you said was good. CA19-9 can also be elevated in pancreatic cancer.
Okay, thank you.
So, sure. Again, if talking about this case, the only suggestion I would make is, hey, I really struggled. We really wanted to try to leave this ovary, or at least a portion of the ovary. But unfortunately, the cyst had gotten so much bigger, there really was no normal appearing tissue from which to separate it.
Okay.
By the way, in a 24-year-old, what would be the most common type of of the ones you talked about? What would be a more one of the more common types of malignancy? And again, it's not common by any means, but if she had in her age group, I guess is the question. What type of malignancy would you think?
Like a dysgerminoma?
Yep, exactly. All right, very good. Any questions?
No, it was the most common cause of ovarian torsion. Was that a dermoid? Okay. Thank you so much. I appreciate it.
You're welcome. Okay, thanks. Raquel, I'm trying to take you off mute.
Can you hear me?
Go. I can hear you. Are you a generalist or specialist?
Generalist.
Okay. Let's see what we got for you. Hang on one second. Okay. So patient number 26 is a 29-year-old G2P0 at 38 and 3. She's gestational hypertension, RH negative, category 2 tracing. You did a vacuum delivery and gave her ROGAM. So where on the fetal scalp do you apply the vacuum when you do it?
3 centimeters anterior to the posterior fontanelle.
Okay, and what are neonatal complications of vacuum?
Some neonatal risks or possible complications include a scalp laceration, like a cephalohematoma, or intracranial hemorrhage.
Okay. What's the highest station you would apply the vacuum?
+3 would be the highest that I would place it.
Okay. Can you tell me the advantages of vacuum versus forceps and vice versa?
So a forceps assisted vaginal delivery has a higher incidence of a greater degree laceration to the mother. So there's a higher risk of 3rd and 4th degree lacerations in the mother. One thing that you can do with forceps that you can not do with vacuum is rotation of the head. But both of them come with similar risks to the fetus. With the vacuum, obviously not. Well, I guess the vacuum, there could be lacerations, but not necessarily just on where the vacuum is placed for forceps. But for example, along the face or the ears, they could also suffer injury there as well.
Okay. So do you routinely cut episiotomies when you do an instrument delivery?
I do not.
So if this particular patient, well, actually, before we go there, well, let's go there. If this particular patient sustained a 4th degree laceration, can you tell me how you would start repairing that laceration?
Yes, I would make sure I have a tech, or usually we can request a tech to assist us with us at the hospital that I am at. I would ensure I have optimal lighting and exposure, and I would first perform a rectal exam to identify the extent of the laceration, and I would start by reapproximating the rectal mucosa using an absorbable suture, so something like a 3/0 vicryl. After reapproximating the rectal mucosa, I would identify the anal sphincter, the internal and the external. I would reapproximate those separately and one by one with the let's see, external. With the internal anal sphincter, I would use also a 3/0 vicryl, and I would try to overlap that tissue in interrupted stitches, and then repairing the rest of the perineal body and the perineal muscle. I usually do that with a 2/0 vicryl in a running fashion, and I use that same stitch to after I come down to come up and reapproximate the skin in a subcuticular fashion.
First of all, would you run the rectal suture, the 3/0 you were using on the rectum? Would you run that, or would it be interrupted?
I would probably do interrupteds there.
Okay. Now, are you actually suturing the mucosa together? So in other words, would your stitch actually go into the lumen of the rectum?
Yes, given that the rectum has been, that the laceration has gone through, yes.
Okay. Do you use antibiotics before you start the repair, or no?
I would use them. I would give her, say, like two grams of cefazolin IV for a 4th degree repair. I would.
Okay. All right. Hey, stay with me. I'm going to bring somebody else in to help us for the next part of the question I'm going to ask. Let's see. Sean, are you there? Sean?
Can you hear me?
Yep. So Sean, let's say Raquel's 4th degree repair breaks down about 12 days after she fixes it. So after the delivery, she comes into your office. You're covering for Raquel, and she comes into your office with a complete 4th degree breakdown. What are you going to do?
One, I want to make sure I can go back and be able to repair that, and so I would, at that point, give antibiotics to try to perform the repair in the OR. I would make sure. One, I do a rectal exam to really make sure I can assess the tear and how far the tears happen with the rectal mucosa. I want to really make sure the suture does not go through into the rectum. I want to make sure this time that when we do the repair, that it's in a running fashion. At least start with that, and then letting the patient know long-term in terms of counseling the risk for fecal incontinence with that breakdown. and possible need for a C-section in the future if she were to have fecal incontinence due to the breakdown of the fourth degree.
So, so you take her back and do the repair straight away. Again, she comes into the office. You're going to post her as an add-on in the evening. Is that right?
If there was a complete breakdown, including of the fourth degree, then yes, sir.
Okay. Would you admit the patient to the hospital or just give her antibiotics, repair it, and send her home?
No, I'd keep her overnight, make sure that we have her on a sort of a liquid and a soft diet, making sure that she's not going to be constipated so that we don't risk breakdown again of the suture material.
Okay. Would you repair the rectal sphincter in any way other than what Raquel described?
Right. When I do the rectal, I do sort of in a end-to-end fashion, but this usually if there's a breakdown, I try to do overlapping. But typically the first time I would do an end-to-end repair, but if there was a complete breakdown, I would do an overlapping fashion the second time.
Okay. Last question about this particular patient. She was Rh negative. If she became Rh sensitized in this pregnancy, how would that affect your management in a subsequent pregnancy?
We want to, if she's Rh sensitized, we know there's a risk for fetal anemia in a subsequent pregnancy. And so I counsel a patient that if there was ever in the future pregnancies, if there's bleeding she has within 72 hours, want to make sure we are able to give the patient RhoGAM.
Do you give her RhoGAM if she's already Rh sensitized? Doctor?
Yes, sir. In subsequent pregnancies, yes, I would still give RhoGAM.
I'm sorry, I didn't hear what you said.
Yes, in subsequent pregnancies, I would still give the RhoGAM.
Even if she's already Rh sensitized?
Yes.
What's the purpose of RhoGAM?
When we give RhoGAM, it's when we're concerned for the mixture of the fetal and maternal antigens. And so the goal is to reduce the amount of antibodies then if there was any mixture of the fetal and maternal blood there.
Okay, I think we'll stop here. Let's go over it, guys. So thank you both. All right, so vaccume versus forceps. So I think Raquel did a nice job of telling us the complications associated with vaccume. Subgaleal hematoma would be one of the big ones we would worry about. Retinal hemorrhage is another thing. I think she said intraventricular hemorrhage, scalp lacerations, cephalohematoma, I think were other ones that she mentioned. She told us in terms of positives and negatives. First of all, she said +3 would be the highest patient she would apply the vaccume, so that's fine. +2 is typically what most of us are going to use, but and that would be a low vacuum delivery at a +2. So, but you know, +3 is her comfort level. That's certainly reasonable. Typically not going to want to do a +1 or above. +1 is going to be a mid pelvic delivery, and you know, unless you're super experienced, and I think most of those practitioners are retired at this point, not going to do those. And even to be honest with you, with super experienced practitioners, it still would be frowned upon, generally speaking. All right, so location of the vacuum was good. Pros and cons. So vacuum's easier, tends to be less maternal morbidity from a laceration standpoint. I think Raquel told us forceps are more successful. You can rotate with forceps, all that's correct. There's more maternal trauma with forceps. You can use it on an asynclitic baby, and the other thing you could do is you can use it on pregnancies or infants that are less than 34 weeks, whereas vaccume, of course, as you know, you can't do that. So I think the next thing we got into was repair of a fourth degree. So, you know, it's not mandatory to give antibiotics now. Raquel, I think, said she would, which I would say is definitely, there's a strong movement toward people getting a prophylactic dose of antibiotics before a fourth degree repair. I guess where I would disagree a little bit, Raquel, would be in the situation in terms of the interrupted versus running. I would do a running suture, kind of like Sean said, and I would also try to avoid, and if I had it happen, I'd have to take the suture out. But you don't want to put the stitch through the rectal mucosa itself. You'd want to go on the muscularis layer just above it to approximate it. If you put a stitch in the rectum, you know, it's set up for a fistula for one thing. And as you know, in general, we would not suture into the lumen of the bowel, generally speaking. So definitely would want to avoid that. I think the two candidates pointed out the differences in terms of how you're going to repair the sphincter. And again, either is acceptable. Used to personally do a more end-to-end in a box stitch. So, you know, basically caudal, cephalad, anterior and posterior relative position would be where I place the suture. I would suggest the 2-0 vicryl at least there, you know, for a little bit additional strength. Let's see. In terms of the Rh negative, what we would do if the patient became Rh sensitized. So in a subsequent pregnancy, we'd be following the Rh, the antibody titers, and we would be looking to see if there's a large increase, like a 4-fold increase in the antibody titers. And certainly if we were, we'd obviously be more concerned that the baby would be at risk for hydrops, not that the baby would be without risk, even if there's not a 4-fold increase, but generally speaking, it'd be an increase in the antibody titers that we'd be looking for. And at the same time, we'd be monitoring the baby for growth and or signs of hydrops. If we discovered that there were signs of hydrops, we would be co-managing this patient, or even if we didn't, we'd be co-managing her with MFM, and the treatment would be, you know, in a severe case of hydrops and or fetal anemia would be, if I'm not mistaken, a PUBS type transfusion. So fetal transfusing the fetus, basically. So let me pause there and see, Raquel or Sean, do you guys have any comments or questions or anything we didn't cover?
No, that was helpful. Thank you. This is Raquel. And I guess when you asked the question if the stitches would be in the rectum, I misunderstood and was thinking maybe it was a tear all the way through, and that, for example, I couldn't avoid not putting a stitch there to put it together. But I see what you're saying. Like if it's not a laceration that goes completely through and down to the rectum, yes, I would want to avoid while reapproximating. I would want to avoid having any suture in the rectum, and would do an exam after my repair to make sure that was the case.
So thanks for the clarifying point, Raquel, but even if there is a complete rip of the rectum, if you will, so I mean, we're talking about being able to see the posterior wall of the rectum. So obviously the anterior is disrupted down through our laceration. Even in that case, you would go on either side of the actual tear in the rectum, and you would suture those sides together. Keep the suture out of the bowel.
I see. Thank you. Thank you so much.
Thank you. One more point. I'm sorry, and I'm glad Raquel brought this up because over. So I asked Sean in terms of repair, you know, how he would go about repairing a complete breakdown. So the idea here is you would not want to take the patient back for a primary repair immediately. In fact, you'd admit the patient, start her on antibiotics. You'd want to take her back to the OR, but you'd want to take her back to debride the laceration. and it may take several trips back to the OR to debride where you have no unhealthy tissue next time you go back to the OR. The idea is to get down to healthy tissue. And if you can get down to healthy tissue, I don't mean just with the first debridement, but you go back, debride it again, or maybe there isn't, but then you're going to observe that tissue for 5 to 7 days, and then you could do a primary repair. The whole point is you want to make sure that there's a time period between when you have healthy tissue and you go back, that the tissue still looks healthy, because the concern is, you debride it now, you get down to, there's blood, you can see bleeding from each side of the tissue, and it looks healthy, it looks good, it looks pink, it's bleeding, but you can't say that it's not been seeded with bacteria, and that 2 or 3 days from now it's not going to look like poor tissue. Your best opportunity, to do a primary reanastomosis is only with healthy tissue. So that's the key thing we're trying to ensure. In the old days, what they would do is they would let this patient heal by secondary intention over 3 months, and then go back and do a revision.
So the idea would be we would still admit them, give antibiotics while they're inpatient, do the debridement until 4 or 5 days has gone by until we see the healthy tissue, sir? Is that
right? So you do the debridement, and let's say you take her back to the OR 2 days later, or examine her, under sedation, whatever. If the tissue looks healthy, obviously you're not going to debride just for the sake of debriding. There's nothing there technically to debride because it's healthy tissue. At that point, you would want to bring her back another, 4 or 5 days later. So it's roughly a week since you did the debridement. The tissue still looks healthy right at that setting in the OR. You could do the repair. It doesn't mean you have to keep her in the hospital the entire time, but you definitely would want her on antibiotics the whole time. It's most likely that an infection would have caused her breakdown. So that's what we almost have to assume, and that's why we'd have to assume the tissue's not going to be wonderful. But if you close it before, again, you're down to healthy tissue that's free of infection, it's just going to break down again. If it breaks down again, the more times it breaks down, as you can imagine, the more difficult it's going to be to repair, and then you're going to have a successful and lasting repair.
perfect? Thank you.
Sure. And then last thing, just to be clear, we would not give RhoGAM to somebody who's already RH sensitized. That horse is out of the barn. Okay?
Yes.
Great.
Thank
Thanks,
you.
Sean. Thanks, Raquel. All right, let's see. Rebecca, trying to get you off mute next.
Hi, can you hear me?
I can hear you now. Give me just a minute. I'll pull up your list. Did you send it in?
Yes, my last name, for some reason, they have it under Maydell, Madell.
Okay. With a D, you said?
Yes, yep, that's it.
Okay, and you're a specialist.
I'm a generalist.
Okie doke. Give me just a second. All right, so patient number 13 is a 49-year-old G4P0, menopausal hot flushes and mood swings. You did an HPI, discussed lifestyle modification, hormone replacement versus paroxetine. She desired a trial of paroxetine. So am I correct in assuming this patient's uterus was intact?
Yes.
Okay. So how did you end up counseling her regarding the pros and cons of hormone replacement?
So this woman in particular was perimenopausal. She had not had a full year of no menstrual periods, but I believe had about 8 months without a menstrual period. But in general, when I'm counseling about HRT versus other options for hot flashes, I basically tell them that hormone replacement therapy would likely help with their symptoms. However, there are risks and benefits to all options. I always talk to them about lifestyle modifications prior to medical management. Things like, decreasing the temperature in the room at night, because generally there are a lot of like night sweats and hot flashes at night. Sleeping with a fan on during the day, kind of dressing in layers, those types of things. And I talked to my peri and postmenopausal women about menopause symptoms in general as being kind of as we think about it in terms of treatment, that we treat it if it's significantly bothersome to them in terms of their daily life. And if they deem that the risks of medical management outweigh, or the benefits of medical management outweigh the risks in their case, as long as there's no contraindications. So when I'm counseling a patient about HRT in general, I always tell them that we have to put them on an estrogen if their uterus is intact, an estrogen and a progesterone hormone replacement therapy to protect the lining of the uterus. And I always specifically mention that because sometimes the estrogen can be transdermal and they have to take a pill or something, and I want them to know why they're taking the pill, that they're decreasing their risk of cancer in that regard. And I always tell them that as we get a little bit older, the risks of blood clots and strokes do go up with hormone replacement therapy, as well as the risk of endometrial cancer and breast cancer. And so we kind of go over family history, make sure that there's no family history regarding those things, and talk about the hormone replacement therapy versus other medical options or non-hormonal medical options.
Okay, so you mentioned, well, first of all, you said this patient's perimenopausal. So how long can the perimenopause precede menopause?
Generally, I'm not sure that there's an absolute answer to that, but I would have to look that up to see if there was.
Okay, and since this patient's perimenopausal, if she had opted for hormone replacement, what would you have started her on since she's perimenopausal?
So in this patient in particular, I could have potentially just started her on like an oral contraceptive, combined contraceptive pill. But because she had 8 months of no menses and was having menopausal symptoms, I probably would have started her on, something like a bijuva, which is generally more for a menopausal patient that has estrogen and progesterone in it.
So, would you caution her about pregnancy if you didn't put her on the birth control?
I would definitely caution her about pregnancy. I do believe that this patient had a tubal ligation, but in general, technically, she could become pregnant if she's on hormone replacement therapy versus oral contraceptives.
So, what route of administration would you recommend for the hormone replacement?
So there are a lot of different routes in terms of hormone replacement therapy treatment. And if their primary complaint is hot flashes, sometimes we go in one direction versus another, like oral versus the transdermal estrogen, just because sometimes the patches can slip if they're sweating a lot, or not stick. But in general, the transdermal hormone replacement therapy is my first go-to.
I mean, why the transdermal? What's that your go-to?
I believe that the transdermal is recommended just because it tends to be well tolerated by women and helps with the hot flashes.
Okay, you mentioned that there's an increased risk with time. You mentioned there's an increased risk of DVT, stroke. I thought you said breast cancer and endometrial cancer, if I'm not mistaken, over time. Is that? Did I hear you correctly?
Yes.
Um, is there an increased risk of endometrial cancer in patients on hormone replacement?
So as long as you're taking the progesterone with the estrogen, the risk would be low, but it's still an estrogen that can be acting on the uterus, and depending on their BMI or other risk factors for endometrial cancer, it could potentially increase the risk.
What about, are there any benefits to hormone replacement other than vasomotor symptom relief?
Absolutely. People generally do get relief from the mood swings as well, although hormone replacement therapy is not generally a treatment specifically for the mood swings that come with menopause. It also is protective against osteoporosis. And so if that's something that we're worried about, that can be kind of a secondary benefit to hormone replacement therapy.
So you mentioned in this patient entry that she opted for paroxetine. What other non-hormonal options do you discuss with patients?
So aside from lifestyle modifications, other kind of medical treatments that I discuss with patients are things like gabapentin, other SSRIs like venlafaxine, and those are generally the non-hormonal options that I try at first.
What about herbals or botanicals?
So at this time, there isn't good evidence regarding the efficacy of the herbal medications, and so or herbal over-the-counter supplements, and so I don't generally recommend them.
What if the patient said to you, she wanted to speak to, she read about a compounding pharmacy in Tennessee that Suzanne Summers gets her medication from? How would you counsel her regarding that? She wants to use natural hormones.
So this is a very common situation, and I generally talk to my patients about the ACOG recommendations and the recommendations of the medical community at this time that compounded bioidentical hormones are not recommended because they have not been studied and they're not regulated by the FDA, and that generally the bioidentical hormones that people get from these compounding pharmacies or from these wellness spas are not overseen by a medical doctor, and that could potentially increase the risks of hormone therapy, especially considering that there have been some studies that have shown that the amount of hormone in them is either greatly increased or greatly decreased from the amount that it has said that's in them. And so it would be less risky for her to go with, a hormone that is regulated by the FDA, and that there is a bioidentical hormone that we can give her that is FDA approved.
Okay. Thank you. I'm going to bring in a colleague real quick. Nasiri?
Hi.
Hi. Anything you want to corroborate or disagree with Rebecca or change, or anything you want to add to what Rebecca was telling us?
No, I would add for the estrogen and progesterone therapy, I do not recall if she mentioned about the for the group with estrogen progesterone that it decreased the risk of the colon cancer, and also it increased the breast cancer in terms of in 5 to 7 years, the chance of having breast cancer is 1/1250. And also the chance of having the there is one more thing. The cardiovascular part. If they start 10 years after menopause, the chance of this increases for the cardiovascular problem.
Okay. All right. Very good. Any other non-hormonal alternatives that you can think of? She mentioned gabapentin, the SSRIs and SNRIs. Anything else you can think of?
I would add clonidine as well.
Okay, very good. Clonidine is correct. Now, Siri, how would your counseling be different if this patient had had a hysterectomy?
So for the hysterectomy, I would say that because she doesn't need the uterus protection, it means that she does not need the progesterone component. That's the reason we do not need to add the progesterone. So in estrogen, people that they just get the estrogen, it just shows that they are not at risk for having breast cancer or cardiovascular problem, and also the chance of the colon cancer, it doesn't decrease in this group. Just they are at the risk for getting stroke and VTE or vein thromboembolism, and also protect them for the osteoporosis and improving the vasomotor symptoms as the other group.
Very good. Well, thank you both. Nice job, doctors. So let's go over it just real quick one more time. So the perimenopause can precede menopause by 2 to 5 years. So certainly patients can be symptomatic, again, for up to 2 to 5 years before they actually have their last cycle and get to a year out of, so we would define them as menopausal. So important, ACOG wants us to recommend the transdermal route. Not saying you can't prescribe the oral route, but the reason for the transdermal is that it bypasses the first pass effect in the liver, which is where the clotting factors are stored. And because of that, it's thought to not stimulate the clotting factors, so there's thought to be less risk of a DVT to the patient. So that's the reason why they want us to recommend transdermal if we're going to put a patient on HRT. However, as Rebecca said, if the patient can't tolerate it, her skin's sensitive, she's perspiring too much and it won't stay on, what have you, obviously an oral route is a very reasonable way to go. Now, in terms of time element, increasing risk of DVT, stroke, I think, and breast cancer, it's partly true. So breast cancer is definitely increased after 5 to 7 years. Stroke is increased in patients in their 70s. DVT risk, though, much of the DVT risk occurs early on after the patient starts using the hormones. And the reason behind that is some of these folks are going to have undiagnosed thrombophilias. So there is some truth, of course, to risk of DVT increasing with age, and that's just common sense in as much as people, as they become older, tend to be less active in general, not always, obviously, but as a general rule, and/or have more comorbidities, more sedentary lifestyle, perhaps weight issues, what have you, and all those things will conspire to increase a patient's risk of DVT. But it's not just the fact that she suddenly started estrogen. It's that at the beginning, people have a higher incidence of DVT, actually in the first 1 to 2 years. In terms of cardiac issues, so again, I think as Nasiri said, if it's been less than 10 years since they became menopausal, there is no increased cardiac risk. In terms of endometrial cancer risk, if the patient is taking the progesterone, the risk should be negated by the progesterone. Trying to think, the 3 non-hormonal alternatives that Rebecca and Nasiri told us about are correct. Botanicals, Rebecca was correct. There is no good data showing that they are effective, although there is some European data that says black cohosh may be used successfully. They haven't been able to reproduce that in this country. But still in all, it is available, and it's kind of, not use at your own peril, but, patients can try it. But the studies that were done with it were done for 6 months. So if you are going to have a patient on it, you would want to advise them, perhaps to taper off after 6 months. It's not known that it's dangerous beyond 6 months, but that was where the study was done. In terms of breast cancer, just to be clear, Nasiri said in a 1 in 1250. So it's an additional 1 case out of every 1,250 women, just to be clear. Benefits of hormone replacement, estrogen, progesterone, just as Nasiri said, so breast cancer, bone protection, I'm sorry, not breast cancer. Benefits of estrogen, progesterone are going to include bone protection, vasomotor symptoms, and colon cancer reduction. Whereas for estrogen alone, it's just going to be vasomotor symptoms and bone protection. There is no colon cancer protection. And I think, but similarly with estrogen alone, there is no increased risk in breast cancer. There's no cardiac issues or concerns. It's really just DVT and stroke in their 70s. So I think that is it for hormone replacement, alternatives to hormone replacement, and route of delivery. So thank you both for.
I'm sorry. Can I ask one question?
Go ahead.
Just because this is something that has come up like quite a bit just in life. Was the answer about the compounded hormones, was that okay?
Yes. So the key thing there, and you covered it well, I think. ACOG does not support compounded bioidentical hormones. Just for what you said, there's no standardization or oversight of the compounding pharmacy. There can be a lot of impurities. There's no standardization in terms of the dose of the hormone that's in the product, whether it's high, low, what have you. The other problem is many of these compounding pharmacies will try to titrate the patient's hormone levels. So in other words, they'll have the patient send saliva sticks back or what have you, trying to measure hormones. Instead of treating the patient symptomatically, they'll treat them to a particular level, which is really not recommended. And I mean, they'll even add progesterone to patients who have had hysterectomies, which obviously we just talked about is not the best thing. It does negate some of the lipid benefits. And they'll even put patients on testosterone. I had a patient that was on 5 times the dose of the highest ester test when it was available. It was crazy.
I was trying to keep my bias out of the question because I have had a lot of issues with this from like wellness clinics and stuff. And so I was trying to keep my bias out of it. So I just wanted to make sure that was an okay answer.
Yeah, no, your answer was good. The take-home message is they think that the class risk is the same, so it's not like they're safer, but the oversight and impurities is the concern. And again, we don't treat people to levels. We treat, for hormone replacement. What we're trying to do is treat them to comfort, and certainly would not want to give them hormones that they don't need, like the progesterone, especially since we know the progesterone negates some of the lipid benefits, and also does seem to increase the risk of breast cancer, albeit slightly.
Thank you.
Thank you. Okay, so let's see. There is a question in the box. The question is, the dose for perimenopause is the same we give for menopause patients. That is correct. If you're going to put the patient on hormone replacement, the dose would be the same. The big concern for hormone replacement in a perimenopausal patient versus, let's say, a low-dose birth control pill is the concern for the patient, that she could still get pregnant. So she could certainly have an ovulatory event and conceive. So that's where the birth control pill is going to offer her some protection from conceiving, assuming she doesn't want to, that the hormone replacement probably won't. But if the patient's either had her tubes tied, obviously she's had a hysterectomy, her partner's had a vasectomy, and pregnancy is not a concern at all, then you certainly could go with, start out with a low-dose hormone replacement and titrate up as needed. Okay, so we are at 9:25. I am going to put down everybody's hand for a minute. We do have one more comment or question in the question box, and then I'll ask people to raise their hand if they have any comments or questions about anything we talked about. Are combination birth control pills then preferred in perimenopausal women who may get pregnant? So I think the answer there would be yes. I would recommend, you could use the super low dose pill, so the 10 microgram pill for these folks would be a reasonable choice. Again, we want to give them as little as possible, but that's still obviously going to be larger than an average hormone replacement dose for a menopausal patient. Okay, so I've put everybody's hands down. If anybody has any comments or questions about anything we talked about tonight or in general that I can answer, especially those of you that might be taking the test this week, please raise your hand. Okay, Nasiri? Let me see if I can get you off mute. There, it says you're
Yes.
there you go.
Hi.
Hi. Did you have a comment or question?
No, I thought that just maybe you want to ask me a question because my exam is this week.
Yeah. No, I'm sorry. We're not going to have time to ask everybody who's taking it this week, but we're almost out of time. This is the
No
going
problem.
over. If you have any questions about the exam or anything that we talked about, I'm happy to try to answer them.
If you can give us a piece of advice, I would appreciate that. Otherwise, I don't have any question.
Okay. I'm going to put you back on mute and I'll give you a piece of advice before we conclude. Give me just one sec. Raquel, let me get your question first, and then I will give you guys words of wisdom for your test.
Can you hear me?
Yep.
Okay. So reviewing my case list, my exams tomorrow. I have quite a few patients that I did an ablation on that I did sampling, via hysteroscopy prior, and I didn't have a high index of suspicion for, malignancy or hyperplasia. Is it going to be a red flag if I haven't done an in-office endometrial biopsy prior to an ablation?
So it really depends on the time period that between your sampling, your DNC sampling, and your ablation. If it's within a year, then no, it shouldn't be a big deal. If she had a DNC, in an effort to control her bleeding 3 years ago, and that's what you're using, and you didn't do a biopsy, then yes, that's a problem.
Mm-hmm. Okay, thank you.
Sure. Okay, guys. I guess there are no more comments or questions, so let me give you the words of wisdom as you go to take your test this week. A couple just general suggestions. Listen to the question that they ask you. Sometimes, they'll say, what's your differential for, I'm going to make this up, dysmenorrhea. And, the candidate, when I'm doing a mock oral, will say, well, this patient's a 45-year-old, G3P2, and start giving me this whole presentation and dissertation. That wasn't the question that was asked. The question was, what's your differential for dysmenorrhea? So I would rather you guys listen to the question, answer the question. Well, dysmenorrhea, the patient can have, endometriosis. She could have adenomyosis, and you can relate it back to the particular patient. You could say she could have, A, B, C, and D. In this particular patient, I think the cause of her dysmenorrhea was D. So again, you answered the question generally, but you related it back to the patient. So do listen to the question, because sometimes, it's almost like ships crossing in the night. Never the question and the answer necessarily match up. The other thing is, speak for as long as you think, you need to answer the question. So if I ask you your differential for chronic pelvic pain, by all means, tell me there's GYN and non-GYN, go through the organ systems for the non-GYN, and to the extent that I'm, as the examiner, letting you speak, start going through she could have, an ovarian cyst, she could have endometriosis, she could have adhesions, keep going as long as they let you talk. But I wouldn't say, hey, well, she could have endometriosis. And you know what? For endometriosis, I'm typically might find some nodularity on the uterosacral ligaments. And if I suspect the patient has endometriosis, I'm going to start her first on continuous birth control pills. So I think you see the difference. That's like now we're already into the workup and treatment. That's not the question they asked you. So let the questions come to you in that respect. Having said that, don't be constipated with your answers, saying things like differential for chronic pelvic pain. Well, she could have endometriosis. Okay, anything else? Yeah, she could have an ovarian cyst. I mean, you can imagine it's going to get monotonous. They're not going to give you the anything else, more than once, certainly not more than twice. So pay attention to the questions, answer it. When you're done with your answer, stop talking. It's when people try to be perfect instead of just being very good. That's usually when that shovel comes out and they start digging that hole where they kind of fall into it. And some people call it going down the rabbit hole. Some people call it digging their own grave. So those would be my words of wisdom for the evening. For those of you, again, that are taking the test tomorrow or this week, I wish you the best of luck. I will look forward to speaking with you guys. I'm not sure when, but I think it's, well, I don't know. I have some other webinars this month, so I know I'll speak to some of you, the December folks, later in the month. In the meantime, have a great night. And again, for those of you taking the test, best of luck to you. Thank you.